I'm going to do is I'm going to go through various items in the program here. And so I've gone from MASLD and MASH in primary care, practical assessment, testing, workflow, integration. And I think this is mainly because I'm going to speed date with this a little bit because we're going to cover a lot of territory. A lot of it will be covered by others, and Jean and both Jeff have already discussed things like FIB4 and some of the sequential testing that we're trying to put in. But a lot of this testing is now going to be done by allied health. I see a lot of primary care practices who have advisors or lifestyle coaches. They have meetings. The patients get really well involved in it. So the 15-minute promise that I've got you here is what you're learning, 4 practical steps. We're going to try and look at what labs to order, how to integrate that liver health into your everyday visits, simple, fast ways to include liver health in the diabetes, the hypertension, the weight, women's health, some of the health checks. So we have NHS health checks, but I know around Europe, different countries will use different health checks at different ages. So when and how to use the non-invasive tests. So clear guidance on FIB4 has already been discussed. Transient elastography, the ELF test, ultrasound, what do they show and how do we use them? And workflow referrals that may well reduce referrals, but increase detection and actually improve the management in primary care. So first of all, let's talk about what the patient actually understands, fears, and overlook. I think we've got to talk about people confused and people think liver disease rather than poor liver health. As we've already seen described earlier today by the 2 previous speakers, a lot of people, we focus on liver disease, but the majority of people will have poor liver health. So when we talk about 25, 17%, 10% having MASLD, MASH, and advanced fibrosis, there are 75% plus patients who will just have poor liver health, who will see an endocrinologist and cardiologist more like. So liver disease is serious, and most people know alcohol is a risk, but they forget that food is a risk, the quantity that we take, the atmosphere that we breathe in, the social areas that we come from. Transient elastography and blood tests help detect problems early, but people are scared of finding a problem sometimes. Obviously, obesity and diabetes increase risk, but slim people have fatty liver too. Different ethnic populations have different rates. So it's about looking at the person as a whole. And it's common, fatty liver is mostly what people call it. I've got a bit of fat in my liver, or somebody told me once that I had that. But we've named it MASLD and MASH, as you've heard. Thus now we want to use non-invasive and quick, where growing awareness of alcohol is not the only cause of fatty liver. So what patients fear? Diagnosis cirrhosis. Most patients don't want to have these tests because they think they're going to have cirrhosis if they've got a risk factor, or it's been in the family. They're scared of cancer, or it's irreversible. The more we know, the more we research liver now, the more we know it can be reversed for the majority of people. So finding it is key. Being blamed. A lot of patients feel they're going to be blamed and stigmatized. Jeff's already talked about patient first language. Needles and biopsies. The unknown. Liver disease and poor liver health is often considered a silent disease, but actually a lot of patients present repeatedly with low-grade symptoms, brain fog, tiredness, snoring, lethargy. These are things you'll see very commonly that are very strongly associated with MASLD and MASH. We overlook the fact that it's reversible in most patients. We overlook the fact that a lot of it is lifestyle alterations that patients will engage with if they're talked to. One normal test, long-term reassurance, small lifestyle shifts, and strong link with heart disease. Most people with fatty liver will die of cardiovascular disease, and we are diagnosing the ones who survived their heart attack post that survival. So we can look at avoiding these. So integrating health into your routine visits. So let's talk about liver health at your diabetes annual review. Calculate the FIB4. You've already talked a lot about that. So the ideal populations, type 2 diabetic, hypertension, high cholesterol, that is the low-hanging fruit. Let's talk to them. Let's speak to them. Let's look at the liver health, hypertension reviews, weights, BMI, lifestyle consultations. Where we're targeting lifestyle, let's put the liver back into the story. Where we're talking about metabolism, the liver is the metabolic king or queen of your body. but it's been forgotten and taken out of the discussion of health over the past 30 or 40 years. So bringing it into women's health visits, vital. Women are the fastest growing referral rate for liver transplantation for something that's locatable, changeable, and reversible. They do not need to make a transplant list. We need to find them early. Once we lose estrogen as women, our progression speeds up. So talking to women is a big thing of what I do in managing diet, looking at lifestyle, those minor treats that can be moved. It really makes a difference. So the key message is liver health does not require additional appointments. They're often part of the reviews that you're doing every day. So clear communication and simple explanation is what we want to look at to improve the liver health. Patients are more likely to understand when you talk about why. Clear, non-judgmental language, because it reduces their fear, it reduces the stigma, it reduces the avoidance. I heard in clinic this morning 3 times from 3 individuals, I needed the conversation why my liver is important to my diet before somebody told me to go on a diet. It makes an awful lot of difference when people understand what they're tweaking, why they're tweaking it. Simple explanations again. Brief focused messages, short, sharp, give them something that they can take away. And why it works in primary care is plain language. Just the check with what we do. FibroScan or transient elastography, we check the liver for its softness and hardness. Relatable comparisons, liver fat builds up quietly, but it's one of the most reversible parts of metabolic health. Show direction, not doom. Liver disease, once we locate it early, can be reversed. But you don't get the opportunity if we don't look. So therefore we can present further disease. So it's absolutely vital. But always pair finding with an action. Your liver fat is raised. Lifestyle changes might be very helpful. So let's look at lifestyle changes you can make. Somebody will always come up with a solution for themselves. Give them the responsibility. So using visual tools, obviously the FIB4, traffic light systems. I'm a great one for color. I color code everything from results. 5 minutes after somebody walks out the room, if it's written down or it's been told to them, they will not remember the numbers. And numbers are part of ranges. So let's color code it. The silent risk. This was a patient who, type 2 diabetic, annual review, 42-year-old male, slightly raised ALT and AST, depending on where you look at that. His BMI was elevated. No liver symptoms though. So his FIB4 at the age of 42, which is a useful discriminator because it tends to be used over the age of 35, and therefore after an older age we change it, and younger you can use it, but you just have to use it with a lot of caution if it's out of the age ranges that we're using FIB4. So more than 1.37 or 1.45 triggers a FibroScan referral of vibration controlled transient elastography or transient elastography if you don't have those terms. So his liver steatosis, which is continual attenuation parameter, was 310. That's steatosis grade 3. Now, I don't like people using the term small amount of fat or slightly raised. Let's be very specific because we can then measure those outcomes. But his liver stiffness was 7.8, so not quite the cutoff threshold of 8 kilopascals, which we've been looking to trigger a referral. But he was motivated. So with simple lifestyle changes, he changed his weight by 7% in over 6 months. So the repeat FibroScan showed the stiffness was down to 5.3, and his liver steatosis was back into the normal range. It reduced it by 75 decibels per meter, and it was down at 235. So we've gone from red on his liver fat and amber on his stiffness to actually green and green. And that's what they remember, that they see these improvements. So keeping it very visual and understandable, all the other blood metrics improved in this patient. But he was somebody who avoided, therefore, a secondary care referral to a hepatologist because all of the changes were made in primary care. That patient now is better managed, has lower problems, and is improving, and it does not need that referral. Women's health. This was a 58-year-old woman who was postmenopausal. Her BMI was elevated at 32. Her LFTs were elevated. She'd had weight gain, poor sleep, family history of cardiovascular disease, and she had a past breast cancer and was on tamoxifen. opportunistic liver health check. Elevated FIB4 at 2.07 requires either ELF or FibroScan. FibroScan was used in this case. So again, high steatosis at 3.378 and liver stiffness of 8.8. So it technically ticks off a lovely referral to a hepatologist. The hepatologist timeline for referral is quite high. Therefore, immediate steps were simple: plan to maximize lifestyle opportunities around her current health requirements, review of medication by the cancer team, and not altered at present. She lost body weight, her weight down in 5 months, 6.1 kilopascals, her liver stiffness came down to, and the liver fat was nearly into the normal range. Steatosis grade 2, but well on the way down there. And again, it's opportunistic. It is helping to manage, and we avoid referrals to secondary care where they're not needed, and the patient improves. And tamoxifen is a known steatotic inducer for the liver. So looking at medications that your patients are on. The key triggers we should really never miss: raised ALT and AST, because they don't exclude fibrosis. Persistently raised requires a further assessment. Type 2 diabetes, BMI of above 30, metabolic syndrome. The liver's the metabolic king and queen, therefore it has to be included in a review. Polycystic ovary syndrome, I see a lot of people with advanced liver steatosis with that. Sleep apnea, it's very difficult to breathe when you've got a big enlarged liver that's full of fat underneath your right ribs. Incidental findings: if you've ever had fat on ultrasound, fat is no longer considered benign. You must do something. FIB4 is the key one for that. Low platelets without another cause, particularly in a metabolic syndrome, is a real key indicator that that patient may be developing advanced fibrosis and cirrhosis. So really be aware of the platelet count. Alcohol and metabolic risk combined. And again, and if any trigger is present, just run a FIB4. Have a look at those for that. Essential 9 labs, the core test that we'd like you to do, or whether you're allied health or primary care: ALT, AST, and some people have to request AST differently: ALP, gamma GT, bilirubin, albumin, full blood count, HbA1c, lipid profiles, ferritin, transferrin, saturation, and hepatitis C and the B antibodies, for example. Why they matter? And I color code them because they show you injury, function, cholestasis, fibrosis risk factors, metabolic drivers, and etiology. So we'll get a complete picture when we consider referring these patients or even assessing them quite quickly. And why this works: it's the structure of how primary care physicians think. It's the way you see your patients. Is there an injury? Is the liver functioning? Is the pattern cholestatic? What's the fibrosis risk? What's driving it metabolically? And colors help us see that, and they help the decision making. So briefly through FIB4, Jean and Jeff have already done this. Jean did it very well. So these are sort of the cutoffs, and you will get these slides at the end. But FIB4 is now our gateway test. It is the one thing that we want you to be able to do and run off. Age, platelets, AST, ALT. It can be done simply by calculating. Transient elastography. This is an in-person test. So therefore, they get brief interventional therapy if it's performed by a nurse specialist. So they get more than just a blood test. Therefore, it is a dynamic test of the liver in the state on time and date that we do it. There is no point looking back 6 to 7 months and comparing it unless there's a lifestyle change, because they're two dynamic states and the liver can change very, very rapidly. The asterisks are here because these are the kilopascal scores that we know work with FibroScan, and therefore not necessarily translatable to all different devices, but they're a gauge. So 8 kilopascals now is considered a risk and therefore a referral trigger for specialist hepatology. But please be aware that the normal cutoff for FibroScan is 7 kilopascals. So below 8 does not mean absence of disease. So therefore being aware of those patients below. Looking at the steatosis levels, there's been a change to MASLD and MASH, where 288 decibels per millimeter is now considered to be MASLD and MASH. But we're enriching the populations when we talk about those levels in specialist care, where we're looking in Primary care, I'm looking for steatosis levels above 2.248, 260, 280, the steatosis grade cutoffs, because they engage conversation so that I don't get patients there. The ELF and ultrasound.
Louise,
Ultrasound
I'm going to
is
have to ask you to wrap
yep,
up. We're a little over
yep.
time. Thank you.
Ultrasound is not a diagnostic tool. It looks at it. It cannot exclude fibrosis. ELF is a blood test you can add into primary care. Where we do an efficiency with primary care, auto-calculate. Let's get the bundles of blood tests. Let's use community transient elastography. We come to your surgeries. Let's build risks, and everybody should know. But the three things take away: FIB4 first, transient elastography, and ELF second thing, ultrasound never for staging, and finally, liver health fits into your existing day, and you're already doing this work. This just makes it more effective. And if it's metabolic, think hepatic. And thank you.
Great. Well, thank you very much, Louise. I don't see questions in the chat, and since we're about at time, I just wanted to ask you one thing. You've emphasized several times that we should start with FIB4, but we also know that there are many challenges with the sensitivity and specificity of this test. And then you closed by sharing a whole bunch of NITs, both, serum biomarkers and imaging that are better. So like in a patient example you provided, a male with type 2 diabetes, high BMI, the kind of person, with the data I showed that there's a very good chance, more than 1 in 3 people in his case would have MASLD. Do you think one should just consider going straight to to a so-called second line test, go straight to imaging, go straight to an ELF, or would you still recommend a FIB4 first?
I think ELF isn't widely available. It's a great test and it's very usable in primary care, but it's not widely available. I think blood tests for me don't give any brief intervention. It's never changed a patient. They don't overly understand them. And I think therefore for FIB4 for primary care, we were missing the majority of people with cirrhosis and liver disease. This is better than it was. ELF gets, and then we want to enrich the patients to get to the right specialist. But for me, being a brief interventionalist, working with real-time scanning, it's about the conversations. Every patient does not feel stigmatized. They have conversations. What can I do about it? How can I change? What can I offer, rather than who's going to give me what pill? And I
No, I
think it's a
understand
change
that,
of dynamic.
but you could still have that conversation if you skipped the FIB4 in what you called an enriched population, someone who has a high BMI and type 2 diabetes, you could go maybe straight to that FibroScan in that conversation. Or would you still want to do a FIB4 risking, a false negative?
I think you could, yes, but I think that's the guidelines at the moment. I think FIB4 relies on abnormal liver function tests. Somebody who's diabetic with a high BMI is less likely to have abnormal liver function tests. The higher the BMI, the more normal the liver function will be. So lack of and a low FIB4 is not necessarily an indicator of absence of disease in that population. So an ELF is a far better test if we were to enrich that population. So my argument would be, yes, let's go for an ELF. If we're really considering somebody who we want to look at, it's going to be more significant, I suppose, than FIB4.
All right,
and I
thank
know
you.
that will set off a debate.
Yeah. No, I mean, and I'm not going to argue for a particular test. I'm just arguing for, do we go for a better test in a population that is more likely to have these conditions, these indicator conditions?